Now, we will continue from the point where we had left over last time about the principles of management of hypertension. The important is the standard guideline and the current practice existing here in the modern practitioners. There is a lot of gap there. The standard guideline given by the group, the major group of cardiology, is as follows. Now, for the sake of clarity, the same algorithm I have just magnified into two slides instead of one slide so that you can see it better. Now, if the person is having a normal blood pressure, let's say between 120 to 80 millimeters of mercury, the suggestion is promote optimal lifestyle habits and observe for once in a year so that if the patient has a risk of hypertension, you can assess it. If it is in the mild elevated blood pressure, where the systolic is in between 120 to 129 and the diastolic is at the range of 80, no medical therapy is to be suggested, no pharmacological therapy. Instead, the optimal lifestyle habits have to be suggested and reassess once in 3 to 6 months. Now, if the patient is in a stage 1 hypertension and the risk for the coronary disorders or peripheral disorders, coronary vascular cardiovascular risk conditions are lesser. That means patient doesn't have the habit of smoking, is not diabetic, etc. Even in that condition, the recommendation is non-pharmacological therapy, no medicines to be prescribed, and reassess once in 3 to 6 months. And if the patient has some risk of the cardiovascular pathology of less than 10%, but not much very high, then again suggestion is a non-pharmacological therapy and see whether the patient has the normal blood pressure or not. If the normal blood pressure is not achieved, then only you have to give maybe the therapy, medicines have to be give, pharmacological therapy is suggested. Even in stage 2 hypertension, the recommendation, the universal recommendation is not to start with the medicines first, only use suggest the lifestyle measures. If the patient, the blood pressure doesn't come under control, then only the medicines are prescribed. The medicines are prescribed only in the stage 3 and stage 4 hypertension, where the patient comes with the certain complications of the hypertension. Now, that is the real target of the planning of the management of hypertension. So, the better suggestion is always the lifestyle therapy than really the medical therapy. But unfortunately, among all the cardiologists and all the practitioners here in India, the moment the patient has a slight hypertension, even in the absence of a hypertension, without proper assessment, patients are prescribed the medicines. Over prescription of the medicine for hypertension itself is one of the major problems now which we see there. Now, the recommendations to lower the BP and decrease the cardiovascular risk conditions by the JNC, that's universal guideline, is to suggest about weight loss. That's the systolic blood pressure will be reduced by around 5 to 20 millimeters of mercury if you reduce weight by 10 kilograms. So, in an overweight person, if the weight is reduced by 10 kilograms, the systolic blood pressure will automatically come down by 5 to 20 millimeters of mercury. And if the person is alcoholic, limit the alcohol. If it's a non-alcoholic, don't suggest that you have to take alcohol and limit alcohol. The alcohol has to be limited, and that is one of the major causes. Reduce sodium intake to no more than 100 millimoles per day. That's 2.4 grams of sodium or 6 grams of sodium chloride. 6 grams of salt is a maximum. And this again would be reducing the systolic blood pressure by around 2 to 8 millimeters of mercury. Then adequate intake of dietary potassium is also another of the criteria. And adequate intake of dietary calcium and magnesium for general health is necessary. Stop smoking and reduce intake of dietary saturated fat and cholesterol for overall cardiovascular health. Engage in aerobic exercise. The most important is engage in aerobic exercise at least 30 minutes daily for most days and this will reduce the systolic blood pressure by around 4 to 9 millimeters of mercury. So, majority of the patients of hypertension, particularly stage 1, stage 2 conditions, can be managed without any medicines. Even in stage 3 conditions, the medical treatment can be reduced further. The 2018 guideline, European Society of Hypertension guideline, recommends that low sodium diet limited to 2 gram per day, as well as reducing body mass index to 20 to 25 kilogram per square meter, and waist circumference to 94 centimeter in men and 80 centimeter in women, can avoid the need for pharmacological intervention in around 70% of the patients. 70% of the patients, as such, that's the issue. And the proven pharmacological, non-pharmacological intervention and its advantages are recorded, standardized, and it's a very well-known issue throughout the globe. But again, as I said, unfortunately, most of the practitioners do not suggest about this issue. The issue is, if the weight loss is done without any medical intervention, weight loss by reducing the weight and body fat, the ideal body weight has to be reached according to the age and height, and expect about 1 millimeters mercury for every 1 kg reduction in body weight. This is what it can be like. And in a patient with the hypertension, the reduction would be more, 5 millimeters of mercury, whereas in a normal person it could be 2 to 3 millimeters of mercury. Then healthy diet, that's what we call as DASH diet. I'll show you the image of the DASH diet, what it is. DASH diet is the diet against systemic hypertension. It's a simple issue. The diet is consume diet rich in fruits, vegetables, whole grains and low fat dairy products with the reduced content of saturated and total fat. Saturated and total fat, mainly the non-vegetarian source of the food. It will reduce the blood pressure in a hypertensive patient by around 11 millimeters of mercury, whereas in a normal person it could be reducing the blood pressure by around 3 millimeters of mercury. Reduce intake of dietary sodium by optimal goal is actually this standard gives 1500, whereas JNC 2.4 grams or 2.4 milligrams or 6 grams of sodium chloride salt as such. It's our aim at 1000 milligram, that's the one which is suggested. It will reduce the blood pressure by 5 to 6 millimeters of mercury in a hypertensive patient and 2 to 3 millimeters of mercury in a normal person. Enhance intake of dietary potassium around 3500 to 5000 milligram by consumption of food diet rich in potassium, not the direct chemical potassium, instead diet which is containing potassium, mainly fruits. It will reduce the blood pressure by 4 to 5 millimeters of mercury in a hypertensive patient and 2 millimeters of mercury as such. The dietary approach, that DASH diet, is what is that? Dietary approach to stop hypertension is DASH diet by US National Institute of Health, which is recommended. The recommendation is grains and grain products should be taken around 6 to 12 times per a diet. This calorie of 1600 to 3100. Each calorie diet should be serving on a 2000 calorie diet around 7 to 8. So amount of the calorie intake has to be decided by your physical activity and body weight. And fruits around 3 to 6 times per day, and vegetables 4 to 6 times per day. Low fat and non-fat dairy products 2 to 4. Lean meats and the poultry, non-vegetarian, would be reduced to 1.5 to 2.5, less than that even. And nuts and seeds or legumes 3 to 6 per week, and fats and sweets by 2 to 4 per week. That would be the recommendation if you have the dietary plan of either 1600 to 3100 calorie diets. If it is at a 2000 calorie diet, the servings are slightly raised. Foods to be avoided during the hypertension, mostly all that junk food, the dairy products, oily food, fat containing substances, these are chocolates, these are to be avoided in hypertension condition. So that's about the dietary and the lifestyle suggestions. The other part is about the medical treatment, the pharmacological treatment. The pharmacological treatment for hypertension is again a confusing area. Lots of antihypertensive drugs and are used in the practice. and they are acting on at different sites, and your selection of the drug also would be again a issue of lots of confusion, lots of difference of opinion does exist, like which of the drug has to be selected. So I will be trying to present a brief of how to select the drug and what are the issues to be considered when you select an anti-hypertensive drug from the contemporary science as such. The major groups of the drugs are the drugs which produce action at the vasomotor center, centrally acting drugs. Among the central acting drugs, methyldopa, clonidine, and guanabans and guanidine are one. At the same time, some of the drugs would act on sympathetic nerve terminals at the ends, like blocking the receptors, alpha or the beta receptors, or both at the nerves. The nerves are blocked by guanidine mainly, and reserpine, the other drug, which will be sympathetic blocking drug. At the sympathetic ganglion, trimetaphone would be blocking the sympathetic ganglion. Beta receptor drugs again, propranolol and other groups of the beta blocker drugs, like I will try to go into a bit more detail about these drugs in detail. Then the angiotensin receptor vessels, like see, angiotensin is one of the most important factor in the presentation of hypertension, as we have discussed in the initial class, like how to about the causes of hypertension and pathology of hypertension, renin and angiotensin conversion, and issue that conversion angiotensin, renin angiotensin conversion can be inhibited by a certain group of the drugs, or the angiotensin receptors present over the vessels can be blocked by certain group of the drug. And so you have two types of ACE inhibitors, the angiotensin conversion enzyme inhibitors groups of the drug, and in angiotensin conversion receptor blockers, ACRBs, ACEs and ACRBs, the group of the drugs. And the drugs which directly act on the smooth muscles, peripheral vascular smooth muscles, so that the blood vessels will be dilated, and this group of the drugs. The drugs which act upon the kidney tubules, like increasing the urinary output so that the total volume of the circulation is reduced, mainly the diuretics, and even the beta receptors to a certain extent act upon the drugs as such. So that's in brief about the types of the drugs which we use. Now I will try to go into very brief group of the drugs which are frequently used and their adverse effects to a certain extent. Now among the oldest group of the drugs which are used in the treatment of hypertension is the diuretics. Among the diuretics, thiazides are one group of the drugs which are used. The thiazides, mainly the common types of the thiazides are hydrochlorothiazide, chlorothalidone, metolazone, and indapamide. Of course, in our context, majority of the prescriptions could be hydrochlorothiazide, and it's considered to be the initial most pharmacological intervention in any hypertension, moderate hypertension, without any complications, where the diet and exercise is not enough to manage. The earliest prescription should be a diuretic, and preferably hydrochlorothiazide, and the dose is 12.5 milligram alone, or occasionally it could be with other drugs. The maximum dose is 50 milligram. Chlorothalidone is the other one. The thiazides actually inhibit the reabsorption of sodium and chloride in the distal convoluted tubule, and hence they act as diuretic. But the long-term use of these may produce a hyponatremia. The other adverse effects are anorexia, confusion, hemopathic structure system may be affected, patient may develop anemia, dizziness, epigastric distress, pain in the chest area, fatigue, headache. These are the common adverse effects of the thiazide group of the drugs. Then among the diuretics, another group of the drugs are potassium sparing diuretics. Potassium sparing diuretics are those which act upon the distal convoluted tubule, and they prevent the sodium reabsorption, but at the same time they will be preserving the potassium, and and such drugs are considered to be even safer in a patient who has a tendency to have hyponatremia, and these would be having a rather more advantage as such. And the drugs are mainly triamcinolone and amiloride. Triamcinolone, the dose is 100 milligram twice daily, maximum is 300 milligram. amiloride 5 to 10 milligram. The one of the important risk with the amiloride is particularly it can result in hyperkalemia, and hence there is always you have to monitor the potassium level, and the hyperkalemia can be quite dangerous. At times it could be even fatal, and with the amiloride that is one of the precaution. So in general the prescriptions of amiloride are comparatively lesser. Triamtidine is another of the commonly prescribed drug as such. The common complications are congestive cardiac failure, edema cardiac, marked hypotension, dizziness, fatigue are the other complications. Then another group of the diuretics are the loop diuretics. Loop diuretics, they act upon the proximal convoluted tubule and the loop of Henle. Loop of Henle, where there will be a continuous exchange of ions, active exchange of ions in the area as such, and this will again inhibit the reabsorption of sodium and chloride, and they are bound to the protein to a great extent, and hence they are considered to be more effective. Among the loop diuretics, the most commonly prescribed drug is furosemide Lasix tablets, which we usually prescribe quite frequently. The dose is 40 to 80 milligram. Torsemide is another relative. Bumetanide. Now, when it comes to a question of different drugs, the difference of action would be very minimal. The group common effect would be same. The potency will be slightly different. So I will not go into the detail of these different potencies. I am just suggesting about the group of the drugs in general. The detailed pharmacology you may read it maybe. The complications, the common complications of the loop diuretics like Lasix like drugs are, one is a major is a hyperuricemia. The uric acid level tends to be raised on continuous use for a long duration, and it's seen in a quite large number, around 40% of the people. Hypokalemia, potassium level may be even reduced in 14 to 60% of the patients. The other complications, particularly when it is injected, anaphylaxis can occur. Anemia, anorexia, diarrhea are the other complications of the loop diuretic drugs. Then the next group is the angiotensin converting enzyme inhibitors or ACIs. Now, angiotensin conversion inhibitor drugs are the now considered as the drug of choice in particularly patients who have chronic kidney disease, proteinuria, etc., renal involvement. In that patient, ACE inhibitors are considered to be quite ideal as such. And they also are known to reduce the mortality rates in patients with heart failure and myocardial infarctions, cardiac involvement and renal involvement. Then ACE inhibitors are the better drugs, and the common drugs which are in that group are fasenopril 5 mg to 40 mg is the usual dose, captopril 25 mg 2 to 3 times, maximum 50 mg, ramipril, which is very more frequently used in among our situation. Majority of the Indian doctors prescribe ramipril, and the dose is 2.5 mg and the maximum is 20 mg. And ramipril has a better advantage over myocardial pathologies than the other way. And enalapril is another 5 mg twice daily, maximum 40 mg twice. Quinapril is one more of the drugs. One of the important precaution is if a patient is on ACE inhibitor and if it is stopped suddenly, it can cause serious life-threatening medical events such as heart attack, stroke, or worsening of the heart failure. Now, this is one of the important issue when a patient comes to an Ayurvedic practitioner, and if you are prescribing some Ayurvedic drugs, and there will be always a question like which of the drugs can be stopped, which of the drugs cannot be stopped as such. Angiotensin conversion inhibitor drugs should not be stopped suddenly. If it is stopped suddenly, it can result in severe complications like heart attack, stroke, etc. Important. And the other complications or adverse effects of the ACE inhibitors are cough, weakness, potassium level may be increased, rashes could occur, rarely kidney failure also could occur. Then comes the angiotensin receptor blockers or ARBs. Now these ARBs are preferred, they act upon the receptor blockers, and in general, as per the general universal guideline, ACE inhibitors are the treatment of choice and ARBs not the treatment of choice. But unfortunately, what happens is now in the current clinical practice which is existing around India, it's the ARBs which are prescribed more frequently than the ACE inhibitors. Majority of the patients who come to us, they would be having some of the ARB inhibitors, and that itself can produce many serious complications. And the common ARB drugs are the losartan, which is very frequently prescribed in many of the patients. The dose should be, initially it should be 50 milligram, and the maximum could be at 100 milligram. If it is prescribed with a diuretic, then the dose should be reduced essentially to 25 milligram, not the higher dose. When losartan has to be given as a single drug, then the dose will be 50 milligram to 100 milligram. But when it is prescribed with the diuretic, then it should be 25 milligram. The other sartans, now a group of drugs called as sartans are used, and these are valsartan. The dose is 80 to 160 milligram, maximum 320 milligram. Olmesartan is another recently introduced drug and quite costly also. The dose is 20 to 40 milligram. Eprosartan is 400 to 800 milligram. Azilsartan 40 to 80 milligram. As far as these differences in the potency and action, not much as such. Only the major difference is about the cost of the drug. The newer molecules, they are more costly. Older molecules are less costly. One of the important precaution is the sartans should not be prescribed in a hypertension with the pregnancy. Pregnant patient should not be given, and if the patient becomes pregnant on a sartan therapy, it should be stopped as soon as possible, because it can cause injury or even death to the developing fetus. Very important. Most of the times this fact is neglected many times in the practice as such. That's one of the important issue. And the adverse effects are chronic cough or dry cough, loss of taste, skin rash, kidney damage is rare as such. Now I am just going into these pharmacology of modern drugs simply because most of the patients who come to us would be on certain of these drugs, and hence you should be aware of these, like when to stop the drug or when to continue the drug. And from that point of view, I am just dealing with the pharmacology of the contemporary antihypertensive drugs. Another group of the drugs are beta blockers, which are generally not recommended as first line agents for the treatment of hypertension. These are not generally choice of drug as such. But again, a majority of the prescriptions which are seen in India by the cardiologists, the usual first prescription would be beta blocker like atenolol, not the chlorothiazide. That's a very odd situation which we see in our surroundings. But suppose if you are starting an antihypertensive drug, I think you should follow that guideline, like initial treatment would be always a diuretic, and if the patient doesn't respond to the diuretic, then you may go for the other drugs. And the beta blockers are mainly when the patients have a complication of myocardial infarction or heart failure or diabetes. Selective beta blockers are often better prescribed than the non-selective beta blockers. The selective beta blockers are bisoprolol, atenolol. Atenolol, metoprolol are non-selective beta blockers. The common prescription is atenolol. Is the drug, 50 to 100 milligram is the dose. Metoprolol is another again commonly prescribed drug among our surroundings, and the dose is 100 milligram to 400 milligram. It could be even presented as extended release tablets. Some of the preparations, now metoprolol preparations, ER or metoprolol as such. Metoprolol extended release tablets will be having a dose of 25 milligram to 100 milligram. Propranolol, the 40 to 240, bisoprolol as such. Advantages of beta blockers are they reduce the cardiac output and they have a cardiac protective role. That's the major advantage. But at the same time, one of the adverse effects of the beta blockers are the beta receptors present in the respiratory tract also would be depressed, and hence it can aggravate this chronic asthma-like conditions. Patients who have chronic pulmonary disorders, obstructive pulmonary disorders, beta blockers are contraindicated. This is important. Beta blockers should not be used in a patient who has a history of asthma or a chronic obstructive pulmonary disorder. It can trigger the acute attacks and it can be quite severe also. In some patients of myocardial infarctions or angina, even a sudden aggravation can occur if the beta blockers are stopped suddenly. So should not be stopped suddenly. The dose should be gradually reduced over at least a few weeks. So if the patient is on beta blockers for a long time, better not to stop it suddenly. It has to be reduced. That's one of the important precautions. Just I have highlighted only those important clinical issues. The other details you may read it from the pharmacology textbooks. The major complications of the adverse effects of the beta blockers, like it can produce a bradycardia, it can produce a feeling of cold hands or feet, extreme tiredness, weight gain, dizziness, depression, and shortness of the breath. The beta blockers with alpha activity, another group of the drugs which are not so frequently prescribed, but they are considered to be more potent than the simple beta blockers. And the beta blockers, along with the alpha activity, they have a peripheral vasodilatory effect, and they block both alpha receptor as well as beta receptors, and hence they decrease the blood pressure without a substantial decrease in the heart rate. That's the advantage. Or cardiac output also is not reduced as a conventional beta blocker. The drugs are labetalol or carvedilol. Carvedilol is often used in our surroundings. Majority of the patients who may have carvedilol as a prescription, and the dose is 6.5 milligram of carvedilol. Labetalol, the dose is 100 milligram twice daily. The maximum is 2,400 milligram. One of the there is a typing error. One of the important adverse effect is blood pressure in erect position is reduced, but in supine recordings may not reduce. This one is not spine, should be supine. One U is missing in my typing. Okay, blood pressure in the erect posture is markedly reduced, but in lying down position the blood pressure may not reduce. So that our patient may even have a orthostatic hypotension, that giddiness in the erect posture. Now that's one of the major drawbacks of the carvedilol therapy or the beta blocker with the alpha activity drug as such. So there you have to depend upon the BP recordings in the lying down posture. Then another group of the drugs are the vasodilator drugs. These drugs will be acting directly upon the peripheral blood vessels, and the peripheral blood vessels are relaxed as such. And this would be having a rather faster effect. So blood pressure would be reduced immediately. But one of the major adverse effect of complications would be the peripheral vessels will be dilated, but cardiac output remains same. And when the peripheral blood vessels are dilated, heart would be pumping more, and hence with the vasodilator drugs there can be more load on the heart. So if the patient has already a coronary pathology, better to avoid these vasodilator drugs as such, because they will increase the cardiac load, cardiac oxygen demand could be increased. And because of the same reason, these groups of the drugs now are less popular, and they are often used only in certain severe cases where otherwise the blood pressure cannot be reduced. They may be used taking all precautions to see that the patient doesn't have a cardiac precipitation. The drugs are hydrolyzine. The dose is 10 mg 4 times daily, maximum will be 25 mg 4 times. Minoxidil. Now minoxidil has become a other prescription of or other indications for the hair growth. At one stage, minoxidil was very popular for the treatment for baldness. Now, of course, that popularity has reduced, but the dose would be 5 mg as a single dose, or maximum would be 40 mg. The major complications, as I told you, are the palpitation due to the cardiac overload, nausea, vomiting, headache, or excessive hair growth. Excessive hair growth can be an adverse effect of minoxidil, or it could be a therapeutic effect needed when the patient drug is prescribed for the baldness. Then joint pain, chest pain could be the other complications. Then another very popular drugs are the calcium channel blockers, and one of the drugs which I usually prefer to prescribe in majority of the patients when I start the treatment. The calcium channel blockers are those drugs which will block the calcium channel in the heart, so that the cardiac output is reduced. At the same time, the cardiac oxygen demand is not raised, so the risk of developing a cardiac complication would be much lesser with the calcium channel blockers. Calcium channel blockers again are of two categories. The one which are the acting upon L-type channels in the vascular smooth muscles, which result in the dilatation. And another group of the drugs which directly act upon the heart as a sinoatrial node and atrioventricular node in the calcium channels in the heart muscle as such, or the sinoatrial node, and their effect would be slightly different. The drugs which act upon the sinoatrial node, the second type, they are more potent than really the other one. Among the first group, the drugs which are used are amlodipine, the dose is 5 to 10 milligram, nifedipine 30 to 60 milligram per day, clevidipine, it's usually injected at a dose of 1 to 2 milligram per hour, and the maximum would be 21 milligram. In case of acute hypertensive conditions where the blood pressure has to be reduced, it should be injected. With the nifedipine, and if it is given sublingually, the effect will be faster, as good as an injectable effect as such. And felodipine, the other one, 2.5 milligram to oral 2 to 20 milligram. The non-dihydropyridines, which act upon the sinoatrial node, would be verapamil. The usual dose is 80 to 240 milligram. If it is in extended release tablet, 180 to 500 milligram. Diltiazem is one more. Diltiazem is having a very specific prescription even in case of sinus tachycardia. Patients who have sinus tachycardia, diltiazem is often prescribed drug. The dose is 30 milligram and the maximum is 360 milligram. If it is extended release tablet, 60 to 200 milligram. And these drugs are quite useful in angina, particularly the diltiazem. Diltiazem is very useful in case of chronic angina with the sinus tachycardia. The complications or adverse effects which can occur, and quite common adverse effects which are more than 10%, are peripheral edema seen in 10 to 30%, giddiness or dizziness seen in 23 to 27%, flushing reddish, this hot feeling over the face 23 to 27%, headache 10 to 23%, heartburn in 11%, nausea in 11%. Less common complications are adverse effects which can occur: muscle cramps, mood change or nervousness, cough, dyspnea, palpitations, wheezing, hypotension or urticaria. They are less common. Then another group of the drugs are the aldosterone antagonists, which block the aldosterone, the antidiuretic hormone as such, and among them the spironolactone is one of the more commonly used drugs. Spironolactone is a specific inhibitor of aldosterone, and the other group of the other drug is eplerenone. The most commonly prescribed drug is spironolactone. Now the patient in 137, that patient is prescribed both spironolactone as well as furosemide together to protect the heart as such. If the serum creatinine is more than 2 milligram, then spironolactone is not indicated. Spironolactone also is very useful, very specific in patients of cirrhosis of liver when there is accumulation of the fluids. There it's a better diuretic than really the other drugs. Like spironolactone also is a potassium preserving diuretic, as in case of the other potassium preserving diuretics. But in the liver failure, chronic hepatic pathology, spironolactone would be having an advantage of reducing the possibility of the impairment of the hormonal functions. So that's a better option there. In hepatic pathology, the hormonal metabolism would be affected. The patient may have that gynecomastia-like symptoms because the steroid hormones are not metabolized properly. Spironolactone would reduce that effect also, and hence it is a better prescription. So that's why usually the common prescribed market drug is laciractone. Combination of furosemide and spironolactone is often prescribed in case of the cirrhosis with ascites and so on conditions, which will having a very potent diuretic activity. At the same time, will have a potassium preserving activity and a defense against the protein, these hormonal issues. But these are contraindicated if the patient's serum creatinine is more than 2 milligram. The other adverse effects of these aldosterone antagonist drugs are dizziness, fatigue, abdominal pain, diarrhea, albuminuria, cholesterol level may be raised, triglyceride level also may be raised, cough are the other adverse effects. Then comes the alpha 2 agonists, which are centrally acting drugs. Again, they are now used mainly in the patients who have very severe hypertension, not in the mild, very severe hypertension conditions. These are prescribed, and these drugs act upon the alpha receptors both in periphery as well as at the center, at the higher center, vasomotor center also, and they will act upon the brain stem mainly. The receptors in the brain stem are affected significantly, and hence the total sympathetic nervous activity will be reduced. They are very effective sympathetic blockers. The drugs are methyl-dopa. The dose is 250 milligram to 1000 milligram. If it is injected, 250 to 1000 milligram infusion over 1 hour, maximum 4 gram per day. Clonidine, which is again commonly prescribed, the doses is the Arcomen is the usual trade name, 0.1 milligram orally twice daily. If it is injected, 100 micrograms per ml. Usually patches are used. Then very splendid has another specific indication in case of cancer-induced pain. Epidural injection of clonidine is one of the remedy where even the narcotic analgesics fail to reduce the pain. Clonidine is often prescribed. One of the major adverse effects of these would be rebound hypertension on withdrawal. If the drug is stopped, there could be sudden hypertension, increase in the blood pressure. So it's better not to stop the drug suddenly. Skin reactions can occur, dry mouth, somnolence, that's moving in the sleep, a tendency to move during the sleep, headache, fatigue, drowsiness, dizziness, hypertension, particularly on epidural. Epidural used for cancer pain conditions. Postural hypertension also can occur in epidural. In case of clonidine, very specific clonidine there. Methyl-dopa, of course, is not prescribed as epidural injection. These are the major adverse effects as such. Then the next group is about the renin inhibitors, directly inhibit the renin system, not the angiotensin, but it's the renin itself is blocked, and they act upon the renin angiotensin system, and they have a effect of even diuretic effect as such. Now, of course, this drug is a relatively new introduced drug, and newly introduced drug, not so very popular. The common drug is eliskiren. Most of the times it is used along with other drug than really as a single drug. Usually it's in combination with the AC inhibitors or angiotensin receptor inhibitors. Then there are patients who have hypertension or type 2 diabetes. There is a very high risk of cardiovascular and renal events. It can aggravate, and that's why eliskiren is a not very popular drug. Not so commonly prescribed. You may not see patients with these prescriptions quite frequently. Diarrhea, cough, rashes, increased serum creatinine, hyperkalemia are the other adverse effects of these drugs. The another more frequently prescribed drugs are alpha blockers. Alpha blockers are the drugs which will block the alpha receptors in the periphery, so they will produce a peripheral vasodilatory activity, and they are not recommended as a treatment for hypertension. But if the patient has a peripheral vascular disorder, most of the times the patients would have atherosclerosis and peripheral vascular disorder, alpha blockers are better prescribed. Alpha blockers have a better peripheral vasodilatory effect, and they also have a effect of reducing the blood pressure. Alpha blockers also have an advantageous effect on the benign prostatic hypertrophy because they will increase the bladder tone. Hence, when it comes to question of indications, the number one indication for alpha blockers are peripheral ischemia, then comes the BPH, and then comes the hypertension. And in hypertension, it is always used along with the other drugs. That's one of the issues. The commonly used drugs are prazosin or terzocin. Prazosin is more prescribed in our situations. The dose is 1 milligram at night or maintenance dose of 2 milligram. Terzocin initial 1 milligram and can raise up to 5 milligram. The common adverse effects are dizziness, drowsiness, headache, weakness, asthenia, that's inability to maintain the erect posture, nausea, palpitation, etc. Then comes reserpine. Reserpine initially was considered to be, it was produced from Sarpagandha, the alkaloid of Sarpagandha. But now the reserpine which is sent in the market is a purely synthetic drug. It's no more an alkaloid from the plant, but initial molecular structure was from the Sarpagandha. So most of the times we Ayurvedic people claim that Sarpagandha is an alternative for reserpine. But I don't use that. That's another controversial. I'll come to that part later on when we go into the Ayurvedic remedy or my prescriptions for hypertension. That will be the next part of our discussion. Now, reserpine is a peripheral acting adrenergic agent, and it blocks the adrenergic nerves by a increased activity. So, when reserpine is given initially, there could be a slight hypertension, blood pressure may slightly raise, and then it reduces the blood pressure in due course of time. And because of that, reserpine now is not so popular, and it is rarely given as a single drug. Reserpine is often now prescribed along with the other drugs, mostly with the diuretic drugs to potentiate. One of the commonly prescribed patent or marketed patent name is edelphenacid drugs, where you have thiazide and reserpine together, which would be a relatively potent drug, and is usually used in severe hypertensions where the patient it doesn't really yield to the usual treatment. Reserpine has also become less popular because of its adverse effects on the psychiatric conditions. It can produce depression, suicidal tendencies, decreased libido, nasal congestion are the other most significant adverse effects. The other adverse effects could be it can precipitate angina, bradycardia, anorexia, edema can occur, syncope, ventricular these arrhythmias could occur, dizziness, depression, lethargy, weight gain, thrombocytopenic purpura, gynecomastia could occur. Now that's about the common group of the drugs. So it's almost a complete comprehensive group of the drugs which are used in the treatment of hypertension. These drugs are to be prescribed at the first outset in the patients who have a hypertensive emergencies, and these hypertensive emergencies are malignant hypertension, hypertensive encephalopathy, cerebrovascular accidents, myocardial ischemia, left ventricular dysfunction, pulmonary edema, dissecting edema, retinopathy, renal failure, angiopathy, hemolytic anemia. These are the hypertensive emergency conditions, and in these conditions only the drugs are to be prescribed. Pharmacological intervention has to be done immediately. Otherwise, always the ideal would be to advise the patients to have a conventional lifestyle management, lifestyle modification, wait for a considerable period of time, then only the drugs have to be prescribed. That is a standard prescription. Similarly, hypertension in pregnancy is another issue. Hypertension in pregnancy is one of the most frequent complications, and it is seen in 10% of the patients, and this again could be having 4 categories: chronic hypertension, preeclampsia or eclampsia, preeclampsia superimposed with the chronic hypertension, or gestational hypertension which is transient during the pregnancy. Now, medical treatment would be required. A direct, immediate medical intervention would be required in case of these drugs as such. And the definition of what I mean by that chronic hypertension, preeclampsia, is a chronic hypertension in a pregnancy is when the patient has a systolic blood pressure of more than 140 milligram and diastolic pressure of more than 90 milligram, and present even before pregnancy or before 20 weeks of gestation, then it's persisting for more than 12 weeks for postpartum. That's considered as chronic hypertension, which requires a prolonged treatment and more energetic treatment. Preeclampsia is a patient who has a systolic blood pressure of more than 140 milligram and has a proteinuria along with that, and which develops within 20 weeks of gestation, and it can progress into severe eclampsia, and hence that if there is a proteinuria accompanied with the hypertension, that's considered to be one of the possible emergencies, and it has to be treated very effectively. And if the patient has a family history of eclampsia, then it has, or renal disease, it has to be very carefully handled. So that itself is another issue. Then chronic hypertension with the superimposed preeclampsia is a new onset proteinuria after 20 weeks of gestation, not at the time of gestation, after 20 weeks, and in a patient who is having a hypertension earlier. That's again another of the emergency, and the risks of sudden increase in the blood pressure, thrombocytopenia, and altered liver function tests could be the other issues with this, and they have to be very carefully handled. Gestational hypertension is a temporary diagnosis which occurs without proteinuria after 20 weeks of gestation, and this is not an emergency. It can be managed only by regular monitoring, and if there is a need, then only it may prescribe the treatment. Monitoring should be very effective in case of gestational hypertension. Transient hypertension is a patient who may have temporary blood pressure on 1 or 2 recordings, but usually it reduces within 12 weeks. But in this patient again, there is no need for continuous or immediate prescription of the drug. It can be managed by continuous observation, but the observation should be more effective. So gestational hypertension and transient hypertension do not require an immediate prescription of the drug. Instead, it should be monitored. That's about the issue. And the guideline would be the guideline in obstetric practice. Pregnancy and hypertension is a different issue compared to others. The guideline would be by the American College of Obstetricians and Gynecologists Committee. I just copied it as such. The guideline is, if the patient has acute onset severe hypertension, then it's accurately measured using standard techniques, and it is persistent for 15 minutes or longer is considered as a hypertensive emergency. If a severe hypertension, grade 3 hypertension, persisting for more than 15 minutes, recorded regularly, would be considered as an emergency. And in that condition, the drug of choice would be intravenous labetalol or hydralazine have been considered as a first line of medication for the acute onset severe hypertension in pregnant women. But the other evidence now suggests that the current trend is to switch over to oral nifedipine, sublingual, as the first line therapy. So either it could be IV labetalol or nifedipine. Nifedipine is quite safer. See, generally I don't deal with the pregnant women for the hypertension, but if there is a situation where it has to be managed, I would always prefer sublingual nifedipine in a patient of pregnancy with the severe hypertension. Then parenteral labetalol is avoided in women with asthma, heart disease, and congestive cardiac failure. That's one of the major issues with the labetalol beta blocker drug. Urgent treatment is needed before the establishment of IV access. If the patient has already eclampsia, then oral nifedipine can be initiated as IV access is not possible. So immediate early treatment where IV line may not be easily available. In such conditions, oral nifedipine is always a better drug. And IV labetalol is the next part of the treatment. Magnesium sulfate earlier was prescribed as an antihypertensive drug, but now it is not recommended. Earlier, the usual common prescription in many of the obstetric textbooks will be magnesium sulfate in eclampsia. But now it is suggested, like the magnesium sulfate is not prescribed as a treatment for hypertension, but it can be a drug for seizures. When the patient of eclampsia has a pronounced seizure, to reduce the seizure effect, the magnesium is prescribed. Sodium nitroprusside should be reserved to extreme emergency. That's the sodium nitroprusside is a most effective drug which reduces the cardiac output, and it's not categorized as antihypertensive. Nitroprusside is used in the treatment of cardiac pathologies, but it can be used as an antihypertensive in case of eclampsia in severe conditions or patients as such. But it should be reserved for only limited conditions as such. Now, as far as the selection of the drugs for hypertension is concerned, the recommendations are as such by different groups. Like, if the patients without any major medical condition, if that's where the patient doesn't have any of the doesn't have any other drug like other complications, then the first line drug to be used is either calcium channel blockers, particularly in African ancestry, that's pigmented conditions in India and so on. The current recommendation is a calcium channel blocker or thiazide diuretic. That's what I said. The first line of the treatment would be always a thiazide or CCP, calcium channel blockers in our condition. And if that doesn't respond, then you may add either angiotensin conversion inhibitors or angiotensin receptor blockers, ACIs or ARBs could be added. If it is still not possible, then combination of these calcium channel blockers plus ARB or thiazide, all the three drugs could be prescribed. Now, unfortunately, most of the market preparations, they are combination drugs. A single patent drug would have many combinations, which produces a lot of confusion with the prescription. Ideally, these drugs should be prescribed separately, though it may increase the number of tablets the patient is taking. Now, the other general prescription in a white or non-African ancestry, that's non-pigmented people, the first choice of the drug is ARB or ACI, and then you may combine these drugs as such. So, in severe hypertension, you may combine these three, or patients who do not respond to the usual medical treatment. If the patient is old age, above 60 years, then you may start with the two drugs in the beginning instead of one drug, either calcium channel blockers or thiazide together. So those combinations could be used as such. That's the recommendation. If the patient has a major medical condition, and the major medical condition is a diabetes as such, and again diabetes with the Indian population, again it's the same, there you start with the two drugs, calcium channel blockers or thiazide together, or if that doesn't respond, then the same issue, ARB or ACA. Then alternative, maybe you may use other drugs as such, the central acting drugs. In white people, like European people, ARB is the first choice of the drug. If the patient has chronic kidney disease, in that condition, the first choice of the drug would be either these angiotensin receptor blockers or angiotensin conversion inhibitors. They are the first choice of the drugs only when the patient has a chronic renal disease. And if that doesn't respond, then the other drugs which could be added in the second line would be calcium channel blockers and thiazide would be added. Then further more drugs like central acting drugs could be added if the patient doesn't respond. Patients with coronary artery disorders, beta blockers plus ARBs, that's angiotensin conversion inhibitors or receptor blockers, are prescribed as the common complication drugs. Like. If the patient has developed a stroke, then the first choice of the drug would be ARB or ACA. That's the drugs. Like. Symptomatic heart failure, beta blockers plus ARB plus ACA, these are the combination of the drugs are used along with the spironolactone. That's as in the patients of 137. These are the common prescribed drugs. This is the standard regimen for prescribing the drugs of acid. Then the next part is how I deal with the hypertension patients with diabetic prescriptions. That's a part which I will be discussing in the coming session. So if there are any questions, I will try to answer and then conclude. Right, there are no questions, so we will wind up today.